All right, and now next up, if you're following the agenda, was what was second in the segment, which is Small Airways Disease by Jeff Galvin from the University of Maryland.
Welcome to a presentation on small airways disease. My name is Jeff Galvin. I have nothing to disclose. Let's start with the anatomy. In the late 60s, Peter Macklem investigated the small airways, or those airways in the periphery of the lung. And yes, they are small, about 1 millimeter, but what makes them unique is their lack of cartilage. Because there is no cartilage, they depend upon the alveolar walls, which are radially attached to these airways, in order to stay open. It's best to look at these airways in the context of the secondary lobule. We can see that the airway is surrounded by this net of alveoli, and the net of alveoli attach it to the pleura. As you take a deep breath, the airway opens. As you blow your air out, the airway gets small. So if you ask somebody to blow down to residual volume, a certain amount of air is trapped in the lung because some of these airways in the dependent portion of the lung actually close. It's important to recognize that these airways are a silent zone in the lungs, and this has implications for us as radiologists. Because it is a silent zone in terms of pulmonary functions, then it turns out that our imaging is very important. So let's look at this concept of the silent zone of the lungs. If you look at on your left, you will see there is a schematic of all the generations of the area from the trachea, which I've circled in yellow, to the respiratory bronchiole, which is one of these small airways without cartilage, very close to about the 20th generation. If we look at the small airway, it's about 1 millimeter. This graph in the center here is the diameter on an exponential x. And then here, if we can see that at about generation 20 is the small airway, about 1 millimeter in size. If we look at the generation 20, we'll see that it has between 3,000 and 5,000 square centimeters of area. So the air in that 3,000 to 5,000 square centimeters must get through the trachea. The trachea is about 2 centimeters in diameter. It's 4 square centimeters in area. So those 3,000 to 5,000 square centimeters of air at any one time must be flowing through the trachea. So it turns out that these central airways have most of the resistance within the lungs. And what that means is that you can destroy up to 20 or 30% of these small airways. And because there's so much resistance in the central portion of the lung, that pulmonary functions are not able to recognize this loss of function within the small airways. And this is important for us in imaging because we have a way to look at it. In addition to pulmonary functions being insensitive, it turns out that histology, that pathologists have a hard time often making the diagnosis. The changes are quite subtle. These are both 1 millimeter small airways. This is the mucosa. There is a band of smooth muscle that is usually applied right to the mucosa. When you begin to get fibrosis in the airway, you will get fibrosis between this circular smooth muscle coat and the mucosa. But the changes are subtle. They don't occur in the complete circumference of the airway. They may not occur in every airway. And very small changes have dramatic effects in flow. So something that you and I might feel may not be evident to the pathologist. Remember that flow in a tube is related to the radius of the fourth power. So for this 1 millimeter image, it turns out that just microns of fibrosis can be very important, something that the pathologist might have trouble assessing. These images came from a study from the AFIP from about a decade ago, and it turns out that this was called normal. The imaging I saw at that time was strikingly abnormal. For us in radiology, this is mosaic attenuation. When you blow your air out and you have this combination of low attenuation and high attenuation lobules, it's evidence of air trapping. And it turns out that the low attenuation lobules are lobules in which the air can't get out because the small airway closed. That area of the lung which has higher density has more normal airways, but recognize that there is a variability from one airway to the next, and that is what allows us to see that. So this indirect sign is probably the most sensitive test in the armamentarium that is available for making this diagnosis. There's also direct assessment of the airways themselves. We can see when the airways are abnormal. If there's abnormal tissue around an airway, we will see the airway within the center of the lobule. This is a beautiful tree and bud pattern in an unfortunate individual who inhaled synthetic marijuana and developed marked injury and organization, so-called bronchiolitis obliterans, organizing pneumonia that obstructed those airways. And if we look at one of the magnified airways, we see the bud of organization. We can see that the airway is splayed and is nearly obstructed. And this nodule are the nodules that we're seeing here. So there's indirect signs, which is mosaic change, and then direct signs in which we see abnormalities of the airway itself. Now, there are a number of conditions which are associated with small airway injury, and I'm just going to cover, obviously, some of them in this very short period of time. So asthma, sarcoidosis, stem cell transplantation, connective tissue disease, diffuse idiopathic neuroendocrine cell hyperplasia, and toxic inhalation. But there are many more, but I will try to use these to illustrate the findings that are important. So asthma, a common problem, and one which is actually increasing. It's usually thought of as reversible airways disease, and it's clearly more than just smooth muscle, although hypertrophy of smooth muscle is common. There's often inflammation and edema, but what often is fatal, this was actually an airway wall that was acquired from an unfortunate individual who died in an acute asthmatic attack, and that person's airways are filled with mucin. You end up having hypertrophy of submucosal glands, and this combination of pathology, along with fibrosis of the basement membrane, are typical changes of asthma. For you and I, on chest x-ray, very hard to see an abnormality. But when you look at the periphery of the lung of somebody with asthma, you can often see these tram tracks, and these are in fact the small airways. We shouldn't see airways out this far. And although this looks relatively benign, as we said, it is the radius to the fourth power change that substantially reduces flow in these peripheral airways. So when you see thickening of the airways in the periphery of the lung, it turns out that that's important. With significant hypertrophy of the smooth muscle, you can end up with mosaic change. This is a 20-year-old woman with very difficult to treat asthma, and even on this inspiratory study, it's clear that she has significant small airway injury, but it's not fibrosis. This is all smooth muscle. Over time, if patients continue to have significant asthma and they have a great deal of inflammation, you can begin to develop fibrosis around the airway, which is one of the reasons why clinicians will attempt to keep people clear of their asthma. And we can see in this patient on this prone study that they have a number of peripheral Y and V-shaped abnormalities within the lung, and this is often a bad sign, meaning that they have persistent thickening and abnormality of their small airways. A similar problem occurs in sarcoidosis, and you can imagine that somebody presents to a clinician with shortness of breath and they're relatively young. Both asthma and sarcoidosis are going to be high on the list. Sarcoidosis is a chronic inhalational lung disease, which involves both the large airways and the small airways. If you biopsy the trachea or the large airways, often you'll find granulomas. Here's a granuloma on a cartilaginous ring. But out in the periphery of the secondary lobule, you can then have narrowing of the airway, but instead of the smooth muscle that we saw within asthma, you now see a problem in which the patient has granulomas which are surrounding the airway and narrowing it significantly. So an expiratory study, mosaic attenuation, but what helps you make the diagnosis in the patient of sarcoidosis is this mosaic attenuation is associated bilateral hilar adenopathy and septal lines. Remember that the granulomas of sarcoidosis follow along the septal lines and along the bronchovascular bundles. Follicular bronchiolitis. This is lymphoid cells which are invading and surrounding the small airways, usually associated with collagen vascular disease, Sjogren's rheumatoid arthritis, also seen in AIDS, and may be an indication of hypersensitivity pneumonitis. Patients with follicular bronchiolitis have typical imaging with, once again, we see direct evidence in which the airways themselves are abnormal. We see indistinct central lobular nodules, and the correlation with this is that the airway has nodular infiltration with lymphoid cells. And sometimes, again, we don't see direct evidence of the airway abnormality. We see indirect evidence, which is once again, we see air trapping. You can see here that the airway is filled with these lymphoid cells, and the narrowing causes this mosaic change. Hypersensitivity pneumonitis is similar in that we will see lymphoid cells in and around the airway, but now you also have granulomas and organization. So in somebody who has hypersensitivity pneumonitis, we will see density and see the airways themselves. Because of the airway involvement, we'll see mosaic change, and the gray area, which is normal in some of the other diseases, is actually also abnormal because you have both granulomas, inflammation, and fibrosis of the alveolar walls. So in this case, both the gray lung and the black lung are abnormal. Constrictive bronchiolitis. This is not really a disease. This is a finding. Again, this is fibrosis, which is between the smooth muscle coat and the mucosa. And when someone has constrictive bronchiolitis, you have to think of a range of diseases from post-transplantation, infection, autoimmune disease, diffuse idiopathic neuroendocrine cell hyperplasia, and a variety of toxins. One of the most common problems within the hospital is going to be constrictive bronchiolitis in people with transplants, allogeneic transplants who have graft versus host. This was an unfortunate 65-year-old woman who had graft versus host after her transplant, fibrosis of her airway, severe mosaic change, and unfortunately on her death, when they removed the chest plate, you can see that the lungs, which normally would collapse, stayed expanded because those small airways were closed or closed even more as the lungs began to shrink. Diffuse idiopathic neuroendocrine cell hyperplasia. This is a group of usually older women who are non-smokers, usually mistaken for asthma. You and I, as the radiologist, are going to make the diagnosis. There are normally neuroendocrine cells within your airways, but in some people, you'll get hyperplasia of these neuroendocrine cells, and it results in mosaic change. And I want to show you that in this case, there are some nodules and some mosaic change, but it's important to do maximum intensity projection to see that there are profusion of nodules that are hard to see without that. And those nodules are related to the neuroendocrine cells which have broken out of the airway. If they get larger, they're called carcinoids. And a minimum intensity projection is key, and I do this on every case within the chest. It takes only an extra 2 to 3 minutes, and you can really see the mosaic change. The mosaic change here is related to airway fibrosis, and that where airway fibrosis is related to what is being secreted by the neuroendocrine cells. The last thing we're going to talk about here is constrictive bronchiolitis related to toxic inhalation. There have been more than 3 million soldiers who have been in the Middle East over a period of 20 years, and they are coming back with significant shortness of breath. And this was a recent article within the New York Times. This is a big thing, and you and I will continue to see these people. You can see that in these open lung biopsies that their lungs are filled with particles. There's evidence of fibrosis, as we can see by the irregular change within their pleural surface. You have to be able to do an expiratory study in order to see the abnormality here. Inspiration will not be adequate. You can look here that this mosaic change is related to the fibrosis that is between the muscle bundles and the mucosa, narrowing the airways, lots of particles from what these unfortunate people are inhaling. And not only do they have airways disease, but they often have significant pleural and parenchymal disease, and that's going to make them have both obstructive and restrictive physiology, and you and I, as the radiologist, are the ones who are going to make the diagnosis. So when someone says small airways injury to you, you have to think of a range of abnormalities from infection to asthma, cigarette smoke, sarcoidosis, transplantation, connective tissue disease, neuroendocrine cell hyperplasia, diffuse panbronchiolitis, and toxic inhalation. And what I wanted to leave you with is that you, as the radiologist, have a certain advantage because you can see individual airways where it turns out the clinician has to use pulmonary functions, and those pulmonary functions are insensitive to the changes that we see in small airway injury. Thank you very much.